Good morning, you guys. I am in the middle of coding a delivery really quick, but I wanted to come on because we really didn't do any coding this week, if I can remember. So I didn't want to go an entire week without giving you guys a coding video. Let me see here. I gotta pull my codes up so that way we can all see what I'm billing on the screen here. But in the meantime, let me figure out what we're going to be billing before the patient delivered. And sorry to jump in without doing the whole intro. My name is Shamira. If you are new to my channel, I am an obstetrics and gynecology coder. So I code vaginal deliveries, cesarean deliveries, female genital system procedures, so vaginal repairs, hysterectomies. I code office procedures, so let's say vulva biopsies or excisions if patients have like lesions or cysts, those type of things that need to be removed. I also code contraceptive procedures, so patients that get IUDs inserted or Nexplanon inserted or removed. What else? Just regular OB stuff, which you would go to your OBGYN for. I code. Mainly procedures only though. I don't code like the office charges. So like let's say you were to go in the office and a procedure wasn't done. Like let's say you were getting like your annual well visit. I don't code that stuff. That's the office that does those type of appointments. But let me see here so I can get this vaginal delivery because that's what we're looking at here. And I think we're going to be billing a routine vaginal delivery, which is our 59400 right here. But I have to go in and look at all the midwife's notes prior to her delivery in the hospital. So let me see how many times she went in to see her before she delivered. So we have 1, 2, 3 times. Okay, so I'm just going to use 3 no charge codes because the hospital admission and all the time up to delivery is included in this one 59400 code, so I cannot bill separate for the midwife going in to check on the patient. But let's see what was happening each time we went in. There was an update to introduce myself to the patient. So this sounds like there was a switch in provider. So those of you that know, that have delivered a child before, you know, sometimes the providers will switch out whenever their shift changes. So that is what she is documenting here. She went in to introduce herself. The next time she went in, there was really no complications at that time. So the reason for her induction, though, it says here, was for oligohydramnios. So that is O41. She's in her 3rd trimester, so we're going to go with O4103X0. Oligohydramnios, 3rd trimester, not applicable or unspecified since there's only one baby. And she is 38 weeks. So those will be my diagnosis codes. Again, it really doesn't matter because we're not billing for this. I just have to have some type of diagnosis linked to these no charges. Let's see here. What else went on? There was a prolonged deceleration for about 8 minutes. So that's going to be the O76. And I'll put that diagnosis code with that code. And I think that's the last time she went in. Yes. What date of service are these? Okay, so that was then. and this was the next day. All right, so now we're ready to look at the delivery. Let me just make sure. Yes. So let's look at this delivery note. I have a midwife here that was working with a resident, so I'm only going to look at the midwife's documentation here. And again, patient here for induction because of the oligohydramnios. And let's read this note. She was attended. Placenta delivered spontaneously, complete, apparently intact with 3-vessel cord. Okay, looks like there was no lacerations. There was an estimated blood loss of 757 milliliters. So in the note it says fundus was firm, but lower uterine segment atony was noted. So for that code, I report uterine atony with hemorrhage 072-1. And I just added that the single live birth, the Z370, so the infant was live born, so I went ahead and added that diagnosis code. After delivery, patient experienced some tachycardia, fatigue, and shivering. Wait, who put that on there? Okay, the midwife did. So for that tachycardia, I could add 9099892 for other specified disease or conditions complicating the childbirth, and then put the ORRO on there. I don't really think it matters really, but I'm just going to add it on there. And then the fatigue and shivering, I'm not even going to add. But let me go ahead and link all my diagnosis codes here and double check to make sure we are billing the 59400. So I have to look at her insurance to make sure it was the same throughout her entire prenatal period, so that way we can bill global. Oh, my code changed. There we go. All right, let's see. Her first OB visit was here, and yes, it looks like she had the same insurance. Let me just see here, because it looks like there was a lot of changes. Right now she has this one that was effective 8/28. So I wonder if they just need to update that. Yeah. Okay, we're good. She had the same insurance throughout the whole time. They just didn't switch out her coverages and update the insurance in the office, but it was effective, even though it was showing that it was inactive. All right, so 59400 is our code. I'm going to attach the LMP, which stands for last menstrual period. It's like a claim. It's it gets attached to the claim. So sometimes the payer wants to know that information and have it on the claim. So 59400 is our code, and I think that's it. Let me make sure my midwife is service and billing provider. And that's it, that's all. So 59400 is our code. Reviewed vaginal delivery. I feel like there was something else that I was wanting to tell you guys, but now I can't remember. I cannot remember. And I just realized because of the angle, you guys would have not even been able to see the code that I chose. Let me zoom in and bring it over here. Can you guys see that now? 59400. That's the code I built for that vaginal delivery. Now I'm gonna move on because I think I just finished all of my inpatient charges for that data service. And I need to see what I have next, probably office stuff. Okay, there we go. That's better. So for that code, we went with the 59400 vaginal delivery routine obstetric care, including antepartum care, vaginal delivery with or without episiotomy and or forceps, and postpartum care. I have some retro charges that just came back to me. What that means is the office or the billers may have updated the patient's coverage. So when that happens, the charges will kick back to my work queue for me to review, but all we have to do is just resend it out. So I don't have to recode it or anything like that. But I did have some that were needing to be sent back out. So let me look at these and send them back out. Okay, so now I have an office charge for an endometrial biopsy. So let's see here. The patient came in today with complaints of postmenopausal bleeding. And we did a biopsy. So postmenopausal bleeding, that's N95-0. That is one diagnosis code. And then for the thickened endometrium, I like to use the R9389. Why we have all these other diagnosis codes on here, I have no clue. Because this was not a routine annual well visit, nor was she screened for HPV. So yeah. Looks like the biopsy says there was just strips of atrophic endometrium, so that is not a diagnosis code. I'm looking at the documentation here for that biopsy. And that's going to be the 58100. Now, can I find these codes right away? Or is it going to take me a minute to find them? We're looking for 58100 here. There we go. 58100 endometrial sampling biopsy with or without endocervical biopsy without cervical dilation, any method. So I'm going to say reviewed procedure. And because I'm not sure about this E&M, I'm going to send it to our claims review analysts. They are the ones that review office procedures. I mean, not office procedures, office charges like the 99212s, 213s, 214s, those type of office procedures that are office, well, I hate to say procedures, but encounters, I guess you can say. They are the ones that review those office notes to determine if the E&M is billable. And because they have all these other diagnosis codes on there, I'm not even going to touch it. I'm just going to send it over there for them to review. So please review to determine if E&M level is billable on the same day as minor procedure. Procedure reviewed and ready to resubmit. Thanks. So sending that over there. And now my next one looks like this might be a prenatal visit. Yes, this was a regular prenatal visit, and we need to be billing the 0502F because of the payer. And looks like they have a G diagnosis. So I'm going to use the 099. What? Okay, she's 24 weeks. So I'm going to add the 099352 because they had the normal pregnancy code, which is the Z3482 diagnosis code. But you can't have a normal pregnancy and then have a diagnosis for a complication. So I'm going to add the 099352. They have the G43.409 and she is 24 weeks. So Z3A24. And then the code that I'm using for the CPT is going to be 0502F. That one is done. Now we have a patient here for a Nexplanon insertion, and they also did a urine pregnancy test, which is the 81025. So I'm going to look at the results of that. It is negative, so I'm going to put Z3202, and I'm going to attach that diagnosis to the urine test. And then I'm looking at the documentation here for the insertion of a non-biodegradable drug implant. So there was a preloaded trocar was placed subdermally and Nexplanon inserted. The trocar was removed. Palpitation confirms placement by provider and the patient. The site was closed with steri strips and pressure bandage applied. So that is 11981. I need my HCPCS code, which is for the drug that was administered, and that is J7307. My diagnosis for those two codes is Z30.017. And that is done. I don't have that picture in my book on my screen, so I wasn't able to show you guys that code. I only have the female genital system section here on my screen. I didn't take pictures of the integumentary system of my CPT book. So let's see here. I have a post-op visit. So this is a patient's 6-week postpartum check. Let me see that we did her delivery. And we did. So let me see. We are going to be billing the 0503F. And that one is done. Next up, we have a patient in the office, which is so funny because it's a pessary check. So in my guide here, in my fancy little guide here that I created, I talk about pessaries and fittings and removals. So right here, I can see that this patient was here for a pessary check, and that means we are not doing a fitting. So we should not be billing for, I actually can pull that code up. Let me see where it is. Is it here? No, here. here. Not there, not there. What is the code? Like 57160? Yes, 57160. Fitting and insertion of pessary or other intravaginal support device. So you have to read the documentation to know if you're billing for a fitting or if you're just billing for the new device that is being placed. And that is the information that I was giving people in this section of my little OBGYN coding guide. So I'm going to look at this documentation and then I'm going to determine if we can bill for the fitting. Now the provider is not billing for the fitting. She's only billing for the pessary, but let's see what is going on here. It says we refit her with a number 5 ring without support and it fell out. We then fitted her with a number 6 ring pessary without support and did well with this. She will return in 1 month for pessary check. She has an appointment scheduled with Urogyne for surgical consult next week. So it does sound like they were fitting her for new ones. So I wonder when the last time she was fitted. So I'm going to go to her charges or her account and I'm going to search that 57160. And I don't see it anywhere. So we haven't billed for her to be fit. So we may be able to bill for this. Let me look at it one more time. She was here for a pessary check. Pessary fell out yesterday and would like another one replaced. Let me look at her appointments. Okay, so it says, oh no, that was this date of service. Okay. There was a pessary evaluation 3 days prior to this one falling out. So let me go look at that note. That's what coding is sometimes. It's a lot of research. You're trying to figure out what was going on. So if you're somebody that's that likes to research or somebody that likes to read, this probably would not be the job or career for you. Okay, patient presents for pessary evaluation for vaginal prolapse. Reports having to go to the bathroom frequently, always has the urge to pee, does not feel like she completely empties. First thing in the morning when she wakes up, she will leak urine. But did we give her anything? Here's our plan. I explained that this is likely contributing to her incomplete bladder emptying because she counseled her about finding of stage 2 pelvic organ prolapse. I explained that given her significant vaginal vault prolapse, she will likely need a sacrocolpopexy, but I recommend she be evaluated by urogynecology for a plan with regard to this. I also explained to her that oftentimes the pessary makes intercourse difficult, but we could try pessary use and see how she tolerates it. A number 4 ring pessary without support was placed today. I recommend she return in 1 month for pessary check. I also referred to her to urogynecology for urodynamic testing as well as evaluation for possible surgery. So she put that on there, and let me see if she even billed for that. So now we have to go back to her account and let's see. Okay, so she did bill for the pessary and it says she billed for a bladder cath, but I didn't read anything about that in that note. Let me go back to it. Oh, right there. Yep, she sure did. Perfect. It says straight cath for 200 milliliters PVR. So she did have that in the documentation. It was just up higher. So she just placed it. So I get why she just billed for the pessary only. She doesn't, it's not clear that she trialed it or that she was like fitting her. But this one says we refitted her with a number 5 without support and it fell out. Then fitted her with a number 6 ring pessary without support and did well with this. So I'm going to add the 57160 here because to me it supports. And had they fitted her a few days ago, then I would probably say no, we should not be billing that because we just fitted her for something else. But that was just her placing one and it happened to be the wrong size, so we actually fitted her this time. And I'm agreeing with the 57160 and billing for that new pessary, which is the A4562. All right, next up, I am looking at an outpatient surgery. So this is going to be for a robotic assisted total hysterectomy with removal of tubes and or ovaries, bilateral, and also salpingo. Well, that is, it says tubes and or ovaries, which is a salpingo oophorectomy when they take both of those. And then we also have a TVT, which is a tension-free vaginal tape procedure. Usually if the patient has like some type of bladder incontinence, we would do that TVT procedure, which is basically taking the urethra and creating some type of, it's hard to explain. I can see it in my head because I've watched them be performed on YouTube, but they are just raising this up higher so that way the patient isn't having any more complications with leaking bladder, her urine. All right, so let me see here. It's going to be 2 different codes. We're going to have one code for the robotic, well, actually 2 codes for the hysterectomy, and it's going to be your S2900. That's going to go on the claim so that it says like this was done robotically. Our code depends on how large the uterus was, so it's either going to be the 58571 or the 58573, depending on the weight of the uterus. And it did say that they took both the tubes and the ovaries, so that those codes both include removal of the fallopian tubes or not. But let me just pull the codes up so you guys can see what I'm talking about. So I'm looking for 58571 here. Okay, so laparoscopy surgical with total hysterectomy for uterus 250 grams or less, and then with removal of tubes and or ovaries. So if they took the tubes only, you're billing this code. If they took the ovaries only, you're billing this code. If they took both the tubes and the ovaries, you are still billing this code. And this is for 250 grams or less. You do not bill both these codes. You bill, depending if they did this. If they did not do these, then you just bill this alone. This semicolon is where these 2 codes separate. So all this information here is also included with this. I hope that makes sense. And then down here, let me zoom back in. It says the same thing, but this one reads for a uterus greater than 250 grams with removal of tubes and or ovaries. So if they did not remove any of these structures, you would only be billing this code, or you would only be billing this code. But if they did, now you were determining if you're billing 58571 or if you're billing 58573. So let's get into this note. Oh, and then I also have to show you guys the TVT, which is, I think, is it 57288? Yes, it is. So this is a sling operation for stress incontinence. I used to have TVT written in my book somewhere here, and this is probably in like my 2020 book. You guys actually probably can see those notes. Like if you go back into my old videos, you guys will see all the notes that I had in my book to help me along the way. But 57288 is the TVT code that we're going to be billing. So let me just add it here. And then let's go back to the 58571. Okay, because that's probably what we're going to be billing. Usually patients' uteruses aren't over 250 grams. Have I seen it? Yes, but most of the time it's less. So let's get into this op note. After general anesthesia was induced, patient prepped and draped in normal sterile fashion. Usually I just skim through all this because it's usually the same thing. Then prepping the patient with the V-care cup, attaching it to the cervix. Bladder was drained. Abdomen was then approached. So it looks like we're going in for the hysterectomy first before we do the TVT. And camera port was then used to enter the peritoneal cavity. Robot ports were then placed. So whenever I see that in the note, I go ahead and I add S2900 so I do not forget. If it mentions robotic assisted surgery at the top of the note, like in the header, and then it's not mentioned down in the body of the note, I will message my provider and ask them, like, can you confirm that this was done robotically? If so, please add this in your documentation, and then they'll go back and they'll put it in. So the robot arms were then docked to the ports. Left proximal portion of the fallopian tube was descended. The left ovary had a small simple cyst. The robot arms were then docked to the ports, and then instruments were installed. We went to the surgical console, then performed the hysterectomy. Hysterectomy was started by first fulgurating the right superior pedicle of the right side, or not on the right side. The broad and cardinal ligaments then opened on the right side. Bladder flap was developed. Left side fallopian tube was removed by fulgurating across the muscle salpinx. Line. Left uterine was then fulgurated. The vaginal clear was then insufflated using scissors. The colpotomy incision was started. So colpotomy, that is a vaginal incision. They are still working They are still working or doing this laparoscopically. So now they are cutting around the vagina. So you see this picture here. They are creating an incision around the vagina right here, right just below the cervix, so that way they can close this off. So the colpotomy incision was started anteriorly entering, entirely brought around the cervix, entirely detaching the cervix and the vaginal from the vaginal wall. Uterus, cervix, and the left fallopian tube removed through the vaginal opening. So once they cut this around, they then took all those, the uterus, the tubes, and the cervix, and they pushed it through the vagina. The pelvis is examined, no significant bleeding. Vaginal cuff was closed, so now they are closing this off. Pelvis was irrigated, no bleeding could be seen. The left ovary was wrapped in piece of inner seed. So they left the left ovary, which would be on this side of the patient, because we kind of have to see it as opposite. So they left the ovary, but they took the tube. Remember, we are still billing either 58571 or 58573, whether they took one ovary or one tube, it's the same code. A piece of inner seed was also placed over the vaginal cuff. This inner seed that they're putting is just to help with eliminating adhesions, so scar tissue. And all instruments were removed. The gas was expelled. The tracheids were then removed. Incision of the abdomen was closed. Strips and bandages. The TVT was then performed. The bladder was drained. The suburethral area grasped with Alice clamps. A suburethral incision was made. The TVT guide was placed to and through the obturator internus muscle on both sides. The tape was then tightened underneath the urethra. Metal scissors were placed between urethra and the tape. The needles were then Not sure what he meant there. At the end of the tape, the sheath was removed and the tape, the suture introduced, was removed. Midline mark was cut and suburethral incisions were approximated and the skin incisions were approximated with stitches. Bladder was then backfilled with 100 cc's of sterile water and the Foley catheter was removed. Patient taken to recovery in stable condition. So that was it. So we have 57288 for that TBT. Now let's go to pathology to determine what CPT code we're going to use for this hysterectomy. And pathology will be the one to have the grams. So it was 160 grams. So 58571 is our code. Let me make sure I'm still recording. I am, because this will probably be the last case. So now I'm looking at pathology. We have squamous metaplasia, Nabothian cysts on the cervix, and benign endocervical polyp. So that's going to be N84-1. The squamous metaplasia, I think that is, oh my goodness, if I can remember, I think that's going to make me look up dysplasia, which is that N, is it 89? Let me see. No. I hate looking up this code because I feel like I look it up all the time, but I never put a sticky note to just jump to it. So, dysplasia. Dysplasia on the cervix, N87-9. And let's see here, Nabothian cysts. So I do have a tab for cysts. Nabothian, that's N88.8. And then there was adenomyosis, so that's N80.03 for the endometrium. The left fallopian tube, there were no diagnosis for that. So now what I do is after I put all my codes up here, you don't just want to code from what you see in pathology. You also want to make sure that there are no excludes. So now I have to go to the end section to make sure all my diagnosis codes that I have here can be on the claim and that they are not excluding each other. So N80.03. I'm going to start at N80 and I'm going to look for excludes ones. Okay, none of my codes excludes that I have here, so I can keep that one there. Now let's go to N84. And no excludes ones notes there. Now I'm going to move to N87. We have some excludes ones, but looks like none of our codes that we're using exclude, so we're okay to move along. Now we're going to go to N88.8. There is an excludes 2, so that means we can report both codes, N84-1 and N88 diagnosis codes. So I'm going to go down here to N88.8 and look for any more excludes. There's no more, so all these codes that we have here can be reported together. And we have our stress incontinence, which was for the TBT, so that's going to be the N39.3. I'm going to attach that diagnosis code to the 57288 only, because that would be the only reason why we would be doing that one. But for my 58571, I'm going to attach all the other diagnosis codes that I have here. So there we go. And actually, let me make sure if there was a resident in the on the case there was not, so I don't need a GC modifier. Alrighty, that's it for today's video. That was a lot. That was a lot. But I feel like you guys were able to learn something. If you guys are interested, I will have linked below my OBGYN coding guide. For those of you that haven't had a chance to get your hands on it yet, it is in my stand store. But thank you all for watching this video. I will see you in my next one. Bye guys.